Hi, and welcome to the Comprehensive Inpatient Neurological Examination, presented to you by none other than The Shayna Show, NP Extraordinaire. In this video, I'm going to walk you through how I perform a comprehensive inpatient neurological examination, from the way I introduce myself to how I check cognition, cranial nerves, motor strength, sensation, and gait. It is practical, direct, and based on real hospital care, not theory. As a nurse practitioner working on the inpatient setting, I often walk into rooms where patients are overwhelmed, confused, or unaware that they are even about to receive a neurological examination. That's why connection, clarity, and confidence matter. This isn't just about documentation, it is about assessment, safety, and communication. So let's go step by step. If you're looking for chart review or how I prep beforehand, that will be in another video. This one is about the actual inpatient interaction and bedside flow. And just so that you are aware, I am purposely recording these videos in slumpy clothes without any makeup on to show everyone watching that if you have content and you feel that you can help other people with the information that's up here, get it out here. It doesn't matter what you look like. It doesn't matter where you are. You don't have to put on makeup. You don't have to look glamorous. Just hit record. Part 1, engaging the patient. In the inpatient setting, I've made it a habit to always put gloves on my hands when I enter the room. Then I extend my hand out to shake the patient's hand and introduce myself. Typically, there will be other people in the room at the bedside. I make direct eye contact with the patient, ignoring the other people. And I always give them a look if I hear their voice to not answer the question for me. I am talking to the patient. I do not want them to lead. I want the patient to focus on me and answering my questions. I do not want family members to answer questions for them. Connection with the patient and a handshake tells you a lot about their performance level, their awareness, their tone, and coordination, and all while you are introducing yourself to the patient. To perform a neurological examination, I tell them, I am here to check your brain. Typically, I've already looked at it on imaging, and I tell them I have seen it and now I need to know it. I ask them if their providers have made them aware that I'd be coming. If they have or haven't, I explain to them that I'm there for a neuro examination. Many people have never even heard of a neuro examination, and I tell them, I am going to ask you a million questions. Are you up for it? You smile, you make eye contact, and you read their face. You have to know if they at that point have the ability to tolerate the examination so that you can perform your job adequately. If you don't think that they'll be able to get through it, in your mind you have to focus on what you're there to look for. What is the examination about? So that if you only get a few minutes with that person, you get a wealth of knowledge generally on what you're there looking for. I try to make them feel as comfortable as possible. And if they are up for it, I ask them, is it okay if I start asking you the questions? I already have a good idea of why I am there, and I've already spent time on the chart review. So then I start asking them targeted questions. Every exam is different, even for the same diagnosis, because every person is different. Understand the basics, yes, but always know why you are there performing the examination and tailor it to the moment, especially if you don't think the person will tolerate the full exam. Part 2, mental status and orientation. I let them know that after I ask them targeted questions that we are moving on to the examination. And I tell them, there are going to be questions, especially if they're appearing to be oriented and answering your questions that are targeted appropriately. There are going to be questions that you know the answers to. They might seem weird or funny, but please entertain me and answer them. So, the first thing you want to ask every person, no matter how oriented they seem to you, can you please tell me where we are? I want the most detailed description you can give me: floor, facility, hospital name, state, zip code. Then I ask, what month is it? What year is it? What day of the week is it? If you do not know the date yourself, do not ask the patient. That is not fair and it is not appropriate. Once they tell me the day of the week, I ask them, can you tell me the days of the week forward from today? And then, if they're able to do that, I ask them, now, can you tell me the months of the year backward from this month? Then, who is the president right now? And who is the president before him? There are a lot of side eyes that you will get, but we are not there to be political. This is a question of general knowledge in this country and events that most people are aware of. Now, if you can find a better question that your general audience will know, I love to hear it. I have not thought of one myself. Then I test basic math. If I give you 7 quarters, how much money is that? Some people will ask serial sevens. To be honest with you, I don't think that that is a fair question, especially when people are sick. And also, I cannot do serial sevens. So I do not ask patients things to do that I cannot do myself. I ask them to name 3 objects within reach. Then I say, I'm going to tell you 3 words. Please repeat them back to me and try to remember them. I will ask you when I am done, if I remember myself. You use a personal list of 12 mixable words that you yourself are going to remember. You should switch them up regularly, but stick to those words so that you can recall yourself what you asked the patient. Part 3: Language and Expression. I tell them, I need to hear the way that you say certain words with our language. Can you please repeat the following 3 phrases? Today is a lovely day in enter your city. Lovely yellow lilies and no ifs, ands, or buts. You are listening for the coordination of the words, the clarity of the sound, enunciation, slurring, and hoarseness. If you tell them that you are going to ask them to repeat 3 phrases, they will likely not continue to repeat after you. But you have to understand, we are the experts, they are the patient. They don't know what we want, and they're only going to listen to what you say. So please always provide clarity when performing the examination. Part 4: Cranial Nerve Examination. When performing the cranial nerve examination, you want to try to stand directly in front of them. I personally try to stand at the end of the bed when I'm starting out the examination because it is more practical to be at that distance when starting. I ask them to focus on my nose or where my nose would be because likely we have masks on in the hospital right now since the COVID shutdown. I explain to them that I'm going to be checking their peripheral vision. So you ask them to focus on your nose and then you check each field on each side. So you ask them, Please focus on my nose and point to the finger that wiggles. And then you start at the top, you wiggle, wiggle, you go to the middle, you do dual simultaneous so that you make sure they have equal peripheral vision. And then you do the bottom, wiggle, wiggle. It is important to check peripheral vision in all 6 fields in the acute care setting. Once we're done with that, I ask them to follow my finger and I check the H pattern for the extraocular movements, cranial nerves 3, 4, and 6. Then I ask them to give me a big smile and pretend that they're happy. This is checking cranial nerve 7. Then ask them to please stick out your tongue and move it to the right and to the left, cranial nerve 12. Then to puff air in cheeks. Once they're done, you can see the movement of their face and you say, "Okay, great, relax." Then I tell them, "The next part of the examination, I will have to touch your face. Is that okay?" And remember, you have gloves on at this point. And once they answer yes or no, and if they answer no, you cannot touch their face. And it is okay if they don't want you to touch them. But if they say it's okay, you ask them, "Please close your eyes tight like you have soap in them. I am going to try to open them. Don't let me." Then tell them, "Okay, relax, but keep your eyes closed. I'm going to test the sensation on your face." And you slowly move your hands down their face in an E fashion. This tests V1, V2, and V3. You don't want to go on the periphery because you're not getting the inner aspects of their face while testing. Then you ask them, "Does this feel the same on both sides?" You check their pupils with a pen light for equal and reactive constriction. And then while the pen light is lit, you ask them to open their mouth and say "ah." And you tell them, "Please say "ah." What I am doing is I am looking for the top of your mouth called your palate. Do not ever assume that the patients know what medical terminology is. So I'm checking the top of your mouth called the palate to make sure that it rises equally. You ask them to say "ah" again. You shine a light in the back of their throat and check for equal palate rise. If you see it and there are no throat symptoms, do not check gag on your patient. They will throw up and it is cruel and unusual punishment. Then I ask them to push their face on my hand, which is checking cranial nerve 11. Then I also check flexion and extension of the neck. I am in the oncological setting, and the reason that we do this is a lot of our patients are on dexamethasone, and dexamethasone can cause muscle weakness of the neck and the hip flexors. So, as a neurology NP or a neurologist, you want to always be checking for weakness because it's something that you can find before it becomes a problem, and it is our job to try to avoid problems. After this, all your cranial nerves are examined. You also want to make sure that you ask the patient, "How is your hearing?" And you kind of rub your hands near their ear. And if they tell you that they have a problem with hearing, you ask about the history or if they've ever been asked if they need hearing aids, or if they hear better on one side or the other with their phone, or if they have ringing in their ears. You also want to ask them if their smell is appropriate. They will tell you if they can't smell, and there are things that you can do for that, but you don't need to focus on it. You just need to make sure that it's not a problem. You also want to ask them when they eat if things taste appropriate. In the oncological setting, a lot of chemotherapy medications can alter taste, and the person will tell you, "Since starting chemo, my taste has been altered." But it is important to make sure that they have adequate taste so that you're not missing a peripheral neuropathy on their tongue. because if they all of a sudden can't taste anything on one side or the other, that is a separate issue and that is not a chemotherapy-based issue. You also want to make sure that you ask them while performing a cranial nerve exam how their swallowing is. Do they have any difficulty swallowing thin liquids or regular foods? This will tell you a lot about how their throat is working. And if they report problems, it is always important to have a speech language pathologist to come and evaluate them for a swallowing examination. This is always about patient safety, and it is our job as neurology to be asking these questions. Part 5, motor and coordination of the upper and lower extremities. I asked them first, are they right or left-handed? With the opposite hand, I asked them, please touch your thumb to the opposite ear and close your eyes. This is checking coordination and motor strength. Then from there, you ask them to please extend their arms in front of you like they are catching rain. Palms up. This is checking for pronation. Then with your eyes closed, please switch and pretend that you're stopping traffic. Palms flip out. And this is checking for asterixis. Then you ask them, okay, great. Please relax. Then ask them, please make chicken wings with your arms. And what you want to do is press down on each side. Then you ask them to curl their arms up, you press in, you press out. And if you find any pattern of weakness, you have to check their arms individually. Then what you ask them is to squeeze your finger, not fingers, not hand, finger, because sometimes people are very strong, especially if you wear rings in the inpatient setting, and you really want to make sure that they are strong in their grasp, but you also don't want to get hurt yourself. So, after you check the upper extremity strength, what I personally like to do, because I'm already up here, is I take out my vibratory sense and I ask them, I put it on their forehead and I say, does this feel cold to you? Because the forehead is typically an area of the body that doesn't have sensory deficits. If this feels cold, then I test on their chest because in the hospital gown, there's a lot of room here. Does this cold and this cold feel the same? If this is yes, that is a good sign. Then you ask them, is this cold? And you tap it on one of their hands. Is this cold and this cold the same? If this is the same, typically they will not have peripheral neuropathy up here if they don't have peripheral neuropathy down here. That is a general assumption, but it is typically correct, especially when you're doing this coordinated comprehensive examination. You don't want to spend too much time. So if this cold and this cold matches, you can come back to this if you feel comfortable, but don't feel obligated because now you know that the cold matches, so they should typically not have neuropathic symptoms. Part 6, Memory, Recall, and Sensory. I say, do you remember the 3 words I gave you earlier? And let them repeat them back to you. Then after using your vibratory hammer or tuning fork to check the cold sense, what you want to do is also quickly check proprioception. So you take their finger, you tell them, you hold it on either side, not on the top, because this gives sensory information. And you tell them this is down, this is up, and you wiggle it, and then you go up or down, and you ask them. So if they have good proprioception and good sensation, it is okay to now move down to the lower extremities. This is also a good reason to have gloves on because now you are about to touch someone's bare feet. Part 7, balance, gait, and motor of the lower extremities. Just to be clear, I work with resident physicians and medical students. In our hospital, we tell medical students that they should not be walking patients. They do not have the training and expertise to ensure patient safety. And I encourage anybody working with medical students to also tell them the same. Please take away the liability of these training physicians because they already have enough stress to deal with. When evaluating patients in the acute care setting, you also want to make sure that safety is imperative. So, lower extremity strength and gait go hand in hand. This is why I test upper extremity strength and sensation together and then move to lower extremity gait and sensation, because understanding and knowing sensory deficits will absolutely help you determine the safety of ambulation on the inpatient setting. So, because you already have your vibratory hammer out, what you want to do is test all of their sensation. So, they understand the cold sense, go back up to their hand, make sure they remember the cold, and then go to the feet. If they have sensory deficits in their feet, what you need to do is take their socks off, check proprioception, check pinprick, and check light touch all the way up their legs to make sure that there are no sensory deficits. Then you go on, once you have checked sensory up the leg, then you start with the motor exam. You tell them, if they're laying or sitting, I want you to push against my hand as if you are marching. This is checking hip flexion. I am going to count to 4, and you count out loud for them to make sure that they can hold each hip flexor to your strength for the 4 seconds. Then you move down their leg. You have them push their calf against your hand, out and back. And this is checking flexion and extension. Then you have them lift their toes to their nose, testing dorsiflexion and pushing down on your hand like they're stepping on the gas. And this is checking plantar flexion. And once you have determined that the safety of the patient is okay for them to get up, if they are laying down, you ask them, do you think you could sit yourself up for me and see if you can stand? I can absolutely help you, but this part of the examination helps me see what you can do on your own. If you need help, tell me. I will absolutely help you. I have got you. But I just want to see how well you can do it on your own. Also, please make sure you have placed their grip socks or rubber bottom shoes back on them. If they are sitting, I ask them, do you think that you could stand yourself up with your hands crossed with your chest? What you're actually doing is you're checking hip flexion at that point. And if they can stand with no help from their arms, they're typically a 5 out of 5. If they can stand themselves up adequately, again, and you are in a safe situation, like let's say maybe you have someone with you, and even if you found peripheral neuropathy, I ask them, do you think that you could stand for 5 seconds without leaning on the bed with your feet together and your eyes closed? If they think that they can do it, we get them into the position, and I tell them, close your eyes. What you are doing is checking Romberg. A patient is only positive for Romberg if they start to sway. And what this is it's looking for peripheral neuropathy. And just explain to them, throughout the entire examination, there is no right or wrong information. There is only information that helps me help you. Now, if they, again, are in a safe place and the space allows, you ask them to walk forward at least 5 steps. And then you tell them, turn around. And if they can, you ask them to walk on their tiptoes for 3 steps and their heels for 3 steps. And I always tell them, you passed. Now, you have a brain. Last section, you have found that the patient has a brain. If I personally find anything concerning, I explain the findings clearly and kindly. Then I tell the patient the plan if there are something that I know my attending physician will agree with. For example, if you find that a patient has peripheral neuropathy, it is imperative that you send peripheral neuropathy labs. Or if you think that the patient is going to need imaging, please explain to the patient that you have this instinct that they're going to need further imaging. Patients are already very vulnerable in the hospital, and it is not fair to make decisions over their head. Any time that you think that they need more medications or consults, also explain this to them. You want to explain fall risk precautions or needed physical therapy. And tell them, if you are a nurse practitioner, if you're going to be coming back with your attending, who is going to follow up when and why? Is it going to be after they have an MRI, after they have the labs performed, or after you're done presenting the case to your physician attending and you're going back? But either way, after performing this type of examination, you're always going to be going back to the patient's room, and communication is key. I hope you enjoyed this video. Please like, share, and subscribe for more. Thank you.